Thank you. And I just want to tee this up and set it up to say, you know, what's our role going to be in this? And so this is really interesting that we're in Nevada. So what's going on today in Nevada? The caucus, right? So yesterday I came up here because I always want to know where I'm going because I get lost very easily. This is a huge conference room. And I'm coming up and all these people are coming down. Did you see, anybody here yesterday see the people with the Trump signs? Okay. So I'm going down the elevator. There must have been something going on with Trump, right? So I'm going down the elevator, literally, I'm sorry, I'm going up the elevator. Coming down the elevator was the orange-haired one himself, okay? I was about 3 feet from him, and you guys, you gotta see this hair. The color of this hair is unbelievable, okay? It's something I've never seen before. It was amazing. But I'm sort of a political junkie, and I love this phenomenon of Trump, because to me, he's like sort of this ideological candidate, right? Some of these things he's saying, they're really not conservative at all. So let's take healthcare, right? So what does he say about healthcare? Right? He says, I'm going to get rid of Obamacare. Okay, that's the Republican conservative thing. He said, but I'm going to make a beautiful healthcare system, right? Whatever the hell that means, right? What else does he say? I'm going to cover everybody, right? We're not going to leave people dying on the streets. Everybody's going to be covered. So what do we hear in the ED when we hear that? Oh yeah, you've been there. Some of you might be from Massachusetts. Everybody gets a card. Everybody gets covered. They're going to inundate our EDs, right? And so that's what makes us scared. But what we need in population health is really a distributed system of care. And that's what I'm going to talk about today. What are we going to do and what's going to be our relationship in this? So this is sort of the format. I talk about retail customers, but it's really population health, right? So I'm the administrative type. I've worked with a lot of CEOs. I haven't been a CEO because I don't want that job. I've been usually a senior vice president. So this is what we want you guys to do, right? We want you to deliver great service, access, and quality at the lowest cost, right? I'm going to talk a lot when I talk tomorrow about the fact that we send mixed signals sometimes, right? So how do we do this, right? Pricing. It's a function of use rates and unit cost, right? We're pretty good at unit cost. Aren't we pretty good at efficiency? We've driven down costs, we've driven down supplies. We're pretty good at that. The savings is going to come from what? Use rates. Specifically where? Where are we going to save costs in this healthcare system? In the hospital, right? Okay. Hospital utilization, disease management, and sending patients to the appropriate site of care, okay? While providing quality, I won't talk about that, we know what that is, but also access, getting our customers in, getting them into the system so that we can treat them at the right place at the right time. Have we done that? So what's the target? First thing you do, there's two things you do when you first start a population health management system. Number one, the easiest thing, and you're probably seeing this if you have ACOs or any of these risk-based models, number one, get people, you're not going to like this, okay? Keep people away from the emergency department, right? Have you heard this? Yep. But in order to do that, we have to have somewhere to send them if they're not coming to the emergency department, right? And that's what I'm going to talk about, what our role is, okay? Keep them out of the emergency department because we want to keep them out of the hospital because we want to reduce hospital utilization. The second thing, and this is where you guys can play a great role. As a matter of fact, you can play a central role in all this stuff, right? The other thing is find the frequent flyer high utilizers and manage them, okay? So I'm a hospital administrator. I don't know claims data. I don't know what happens in practices. I don't know who these people are. Who knows who these people are? You guys, you could probably give me what, 10 or 20 names? It's shocking when you do this data and you see how many people come to the ED 100 times a year. 100, you're all nodding, right? You know who these people are, so if I'm saying the first thing I want to do is get rid of unnecessary utilization, you can go, here's the list. Let's target these patients, let's find these patients, let's get them into the system, let's do something, right? So that's sort of the first part. This is the patient we're talking about. There's probably two major patients we're talking about. One, substance abuse, right? Psychology, behavioral, I'll talk about that in a second. And this patient. Folks, the thing is, all we're talking about in population health management, and this is why the ED can take a lead in creating this distributed network where we treat people at the right place at the right time, we're just talking about coordinating all this stuff. Look at the different doctors, the different meds, the different conditions. All we're talking about is coordinating this stuff. This woman is one of your 100 or 50 people. She comes into your ED all the time. Which of these problems are you treating? Probably one of them at a time, one or two of them at a time, right? So that's sort of the issue with the patients that we're looking at. The other thing we're trying to do in population health is optimize what we call healthcare touch points. Whatever the patient needs, medication reconciliation, basic exams, diagnostic testing and evaluation, we need to redefine the roles both in the ED and in all these other settings too. So let's get into this, okay? So this is sort of the key components of a population health management delivery system. So you have what happens out in the community, and that's disease management, behavioral health, and wellness. You have what happens in the healthcare system. First, they got to access the system, you navigate the patient through the system, and finally you provide case management once they're in the hospital to most effectively manage that length of stay. Then you have what happens after they leave the system, the post-acute, which is the care transitions, long-term care rehab, and home health. These are sort of the five that the ED's directly involved in. And I'm going to touch on these briefly. Most of this talk is going to talk about access. That's the one that we really want to focus on because that's the one that's really going to directly affect the ED more than anything. Okay, so briefly, disease management, okay? This is really something that happens out in the practices mostly, but when these people, when that woman that I showed you, when she shows up, she's a VIP now, okay? We've got her identified in our system, and we know what happens with her, and so we're going to provide disease management. So what the ED can do in disease management is help us identify these patients, flag the VIP so when they come in, understand there's a care plan somewhere, access the care plan, access the primary care physician, and get engaged in that. And finally, engage the primary care physician for follow-up. Okay, this is the one that I know, for those of you that work in the ED, you spend a lot of time with these people, right? And they take away, and they're very resource intensive, okay? We on the hospital side, we have done a lousy job with behavioral health. We have gotten out of this business in most cases. And you guys, you don't have anywhere to send these people. You have to manage them in your ED. There aren't beds available, okay? So in the future, what we're now setting up are these systems of care for behavioral health. We're actually getting back into the business. You're seeing expansion of inpatient behavioral health and psych beds in hospitals now. There's very aggressive case management where we can deal with these people and we can try to find the resources out in the community. And there's a wealth of resources out in the community where you can actually refer these patients, right? And then, of course, there's a whole issue of substance abuse, pain management contracts, and people, drug-seeking patients. Okay, I just want to touch on that briefly because really this is about access. What we want is we want these patients to be accessing the system. We don't want these patients not accessing the system, not going to their doctor, not going to their urgent care until they get so sick they come and see you guys when it's down the road. We want them accessing the system at the appropriate point of care. And it's sort of interesting if you look at it from a business perspective. Most businesses go out there and really try to find customers. We have customers. They're out there. They get sick. They can't get in. We don't have the access points, and we don't have the capacity. This is a survey from the Commonwealth Fund that shows that more than 2 out of 3 adults have difficulty getting timely access to the doctor. Same-day appointment, 29%. By phone, 39%. Getting care on nights, weekends, and holidays, 58%, 71%. Our access is pretty bad. We need to improve our access, okay? But what do people want when they say access? And I apologize if you can't read this. But this is actually, when we think about our role in the ED and access, this chart is really good news, okay? The first one says, this is from the advisory board, top 10 preferred primary care clinic attributes. Number 1, I can walk in without an appointment and I'm guaranteed to be seen within 30 minutes. The first part of that statement is the ED. For some people in this room, the second part of this statement probably fits, but maybe it doesn't, right? So that may be our challenge. If I need lab tests or x-rays, I can get them done at the clinic. The provider is a network for my insurer. The visit will be free. Good luck with that, right? How about this one? Very high attribute. The clinic is open 24 hours a day, 7 days a week. okay? I'm gonna talk about urgent care in a couple of minutes, because I've done a lot of urgent care business plans. There's nowhere where we're gonna be able to do urgent care or primary care or physician care 24/7 and make it pay from a business model perspective. There's only gonna be one place, guys, that's gonna be open 24/7. You know what that is, right? And people want that type of open access, so that's very good news. But if you look at also the, some of these lower ones, I can get an appointment later today, the provider explains the cause of my illness. They're not as important. I like this one too. Each time I visit the clinic, the same provider will treat me. Very low on the scale, okay? They just want access and get in. And that's why we're seeing the whole system changing, all right? So here's the old model. We really didn't have a lot of access points. You got sick, maybe you could get in to see your doctor or not see your doctor, but I'm just talking, for the purposes of this talk, about unscheduled care, okay? Not appointment care, unscheduled care. So you either took care of yourself, you went to the ED, and the idea was to drive it into the hospital, okay? So here's the new model. Here's what we want to do. We want to drive care to the lowest cost setting as much as possible. And this is sort of the thought experiment that I want us all to think about over the next few days, because like Sherry said, we're going to have a group conversation about this, I think, on Thursday. What's our role in the ED in all of these other things, okay? Moving down to urgent care, convenient care, retail clinics, and then one I want to spend a couple minutes talking about, which is virtual care. Okay, so if the idea is to drive care to the lowest setting, what's our appropriate role in here, and how can we even keep care in the ED and compete with some of these other types of places? Okay, urgent care, all right? Not a great business model if you're a hospital. If you're a hospital trying to either divert or unload some business from the ED or create access points, it's not a great business model. That's why you're not seeing hospitals being very successful in this. And there's a couple of reasons for that. One is sort of the level of care and competition or collaboration. So I was in a place, we developed an ACO, clinically integrated network. So what was the first thing we wanted to do? Get patients out of the ED, right? So what we said was, let's find one of these urgent care companies that already has 7 urgent cares in our market and see if we can do a deal with them. Guess what? They love to do a deal, okay? But it was really surprising. The level of care, they're not talking about the 1s and the 2s, they're talking about the 3s and the 4s too, all right? They're really moving up the level of care, so it sort of makes me question it. The other problem is payer issues, okay? In most states, you have to have a separate urgent care rate that has all kinds of stipulations on it. So it's either commercial insurance or cash. Here's the secret about the urgent care guys. You probably know this. They don't take non-pay, all right? If you don't have an insurance card, if you don't have cash, generally these visits are like $160, they don't take you. That's a real challenge for us in the hospital industry, right? This issue about direct admits, okay? This came up when we were talking to them. And here was their theory, and I'm not agreeing with this, I'm just putting this out there, okay? If we're seeing very complex patients in the urgent care setting, we work these patients up, okay? And we actually make the determination that this patient should be an inpatient. What do we do? Call you guys in the ED? Is there a way that we can direct admit? So I just put that out there as sort of something to think about. The good thing is that we can generate a lot of referrals to our specialists that are in the network out of the urgent care, so that's something that benefits us. And also they're going to help us with our attributed population health management. So if we have that woman that you saw on the slide and she needs to get in and it's a relatively minor thing, we can get them into the urgent care knowing that they're going to collaborate with the hospital system. Okay. To me, this is the way I define it. Urgent care is more emergency care light. You see a lot, in urgent care, you see a lot of like, rule out fractures, get a basic x-ray, or if you're bleeding and need sutures and things like that. The other piece is sort of the medical side of this, right? What we call convenient care. What you're now seeing probably in your primary care physicians doing extended after hours care. So this is, walk-ins. This is an ad that I found from hospital systems. So when you need medical help, where should you go? Another piece that you may want to do is something like a call center where somebody says, I have symptoms X, Y, and Z. Should I go to the ED? Can I go to my convenient care clinic? Or can I just wait and see my physician, my primary care physician tomorrow, if I can get in, actually? Two pieces about this. Well, one is the post-discharge care. So we have a huge problem, and this is actually something that Sherry and I have sort of tossed out, okay? What you want to do in care transitions if a patient is discharged from the hospital, one of the first things they need to do is to see a physician for follow-up in the next few days. You'd be shocked, we can't get these patients into their primary care physicians for 2 or 3 weeks. So somebody gets discharged from the hospital, that's one of the biggest predictors of readmission is whether they get seen by a physician in 2 to 3 days. So one thing you can do if you don't have a lot of capacity, you can actually set up these clinics so that the patients can come in for their post-discharge care. But there's 2 things that I noticed in a market I was in recently. I wonder if anybody else has noticed this too. So we were really, our pediatric visits were really going down. We were wondering why. So we asked the pediatricians. What we experienced is now they're staying open until 6, 7, 8 o'clock at night, or just staying over. And they're saying to the parents who call in, and when they would formally say at 5 o'clock, I'm going home, go to the ED, we'll see them in the practice. The other thing, there's a lot of innovations that we can now do. So we worked with our cardiologists and came up with a program for our congestive heart failure patients where they would actually do infusions in the cardiologist's practice if they needed LASIK. So these are just some sort of examples of how you can be creative in these. Now, this one, retail care. I don't know what there really is to say about this. The one thing is that if you talk about Walgreens or Walmart, they obviously have a ton of distribution points that already exist that we can't really compete with. They're very convenient, but it's a very, very low level of care. But there could be a way that we could potentially collaborate with them. Okay, this one. Is anybody doing this? Does anybody have something where there's an app? This is Jefferson in Philadelphia, where there's an app where I can actually access an emergency room physician and talk to him or her? Nobody's doing that. That's fascinating. They, this circle, I know it's hard to read, but they essentially integrate virtual care into everything. So not only into the ED, but urgent care, e-visits, remote monitoring, post-discharge follow-up. So the ultimate is that people don't even come in to a facility. If there's ways that you can use FaceTime or Skype to see patients, that's another evolving technology that we're starting to see. So this is driven by the ED, okay? They're actually driving this. So that's just a question to put out there. So just to sort of summarize real quickly about access, what can the ED do in access is to help be part of the solution, work with the system, help design call center protocols. So if there are places they could go to the retail clinic, the convenient care clinic, the urgent care clinic, or the emergency room, you actually have a role in that so that you're actually getting the patients into the ED that you need to get in. And then potentially talk about urgent care, retail care, should we get into that business and can we manage it? Okay, I just want to touch on a couple of other pieces on this entire continuum. One is this whole issue of case management. So just as a preview, I'm going to talk about this tomorrow when I talk about this sort of, very conflicting instruction you're going to get from hospital administrators. In other words, I want to make sure my admissions are as high as possible. Because remember, we're still transitioning into this population health. Even the most aggressive population health, ACOs for example, or risk-based models, you're only talking about 10, 20, 50,000 patients. That's not going to be all your patients. So there's still a role for trying to make sure that case management is appropriate, that people are either being seen where they need to be seen, or if we can generate an admission, that the case manager actually plays a role in that. Because the worst thing, and I know Dr. Seberg is going to talk about this a little bit in his talk, is this whole issue of observation, okay? We hate observation, all right? we think, I know that there's reimbursement for it, but the problem with observation reimbursement is it's sometimes a half or a third of an inpatient, and guess what? It takes as many resources, if not more, all right? So we either want from you to help us say, let's make sure that this patient has criteria, and we can document the criteria for admission. If not, let's find somewhere else in another site of care. I know that's easier said than done, but that's something that we definitely focus on. And the other thing is this whole issue about the access or the convenient care clinic to help us coordinate discharge assistance. And then finally, this issue of care transitions, which is when the patient has been discharged from the hospital, as you know, with certain conditions, if they are readmitted to the hospital within 30 days, that's a big problem for us. So the essential role of the ED is helping us flag patients with recent discharges, identify and manage the visit, collaborate with PCP. Another big issue that we found is a lot of time these patients are coming back, and it really has to do with end-of-life situations, and are we really coordinating those end-of-life situations as we should be. So the bottom line, here's the bottom line, is putting it all together is you want to drive care to the lowest cost setting, whether that's pre-acute care or post-acute care. So the question is, what is our role in that, and how can the ED be fundamental to that? So I want to just leave you here with a couple questions just to think about, okay? One is this whole issue of your business is really an episodic care business, right? Somebody comes in, they have something specific, how do you treat that thing, and then move on. But what we're really looking for is that coordinated care, like we saw with that lady, right? To not just say we're just treating the one symptom, but what are the other pieces that we need to help coordinate that care? So how can we become an integral part of that system? What's our role in developing the distributed network system of conveniently located services? How do we participate and collaborate across the spectrum? And what are the other business lines, service lines, whether it's urgent care or convenient care, that make sense for us? And we'll have more discussion about that over the next couple days.